Good morning. You're listening to Insurance Matchmaking, your path to health, life, and Medicare coverage with Matt Libby Insurance. And now, sharing his knowledge, here's your host, Matt Libby.
All right, good morning. Welcome back to Insurance Matchmaking. I know I'm probably feel like I'm beating the dead horse. I've got a lot of stuff I want to reiterate. There's been some developments come up in my side of the things with the health and the Medicare. And so I just kind of want to reiterate some of the stuff that, like I said, I've been harping on a lot of this, but it's coming up on me. I think I'm starting to feel a little overwhelmed because we're at the middle of September here, and I've got a couple trips out of town business-wise that are cutting into my prep time for October. And by the time you hear this, it's going to be right around the corner. So I really want to push on that. There's a lot of change going on in the Medicare field right now. A lot of those changes in Medicare are, and still, most of it goes back to that Inflation Reduction Act, which changed how much the insurance companies were having to pay for the prescriptions once people hit their $2,000 maximum. Back when we had the infamous donut hole, they had to pay a little bit extra on when someone would hit that catastrophic cap, but it wasn't as high a percentage as it is now. It was like in 24, it was like 20% of the cost, and now they have to pay. Gosh, I should have it in front of me. Started 40. It's like 60% of the cost is going to be on the insurance company. So people that have those, $1,000 a month or $15,000 per dose, like maybe they take it once a month or once every 3 months, but it's several $1,000s, and the insurance company's now going to have to pay 60% of that. They've got to shift those costs somewhere else, and that's affecting people in my field a lot because a lot of the plans are going to non-commissionable. Now, we know in mid-year this year we had a lot of the plans went non-commissionable because they weren't profitable because of not just the prescription cost, overall health care costs going up and causing the insurance company to pay more to cover that person. So they love that person who goes to the doctor twice a year for a checkup and only takes a couple of prescriptions. They make money on that person. They don't have to spend a lot on them. But the ones that have a lot of health needs, have very expensive drugs, the insurance company's paying more for them. And they've got their what we call the actuaries. They figure out how much it's going to cost them to cover these people, or they make estimates and they put their bid in, like in June of the year, May or June. I think there's a deadline. I think the deadline may be in July for them to get those bids to CMS and say, this is how we're going to cover on our plan next year. This is what we're going to put as our max out of pocket. This is what the copays are going to be. This is what we're going to offer for over-the-counter benefits, Part B givebacks. All those little added benefits go towards how much they have to put out for aid, because basically the way CMS looks at it is they subsidize the Medicare Advantage plans generally at about $1,000 a month. So that's why you can have a zero premium Medicare Advantage plan. And then it's up to the insurance company to try to avoid as much cost as they can. That's why they like the managed care plans. And I'll talk about those managed care plans, the difference between HMO and PPO, while they're doing it. But anyway, they have to spend, they're supposed to spend 85% of what they receive from CMS to what's going towards the member, the pay, or the enrollee, the policy holder. So now they can have those copays, so that helps them defer. That's some of the cost sharing. But there's also that maximum out of pocket. So when you hit that maximum out of pocket on your health care costs, you don't pay any more copays. The insurance company's covered 100%. And it happens very rarely. It's only going to happen when people have very serious health conditions, something like cancer, where there's a lot of ongoing treatments, and even a long hospital stay. I always have to explain to people, a long hospital stay is not going to make you hit your max out of pocket with a Medicare Advantage plan, because one of the ways they do their cost sharing on that is they charge a copay per day for a set number of days in the hospital. Generally, most plans, it's like at least 5, and I've seen some go to 7 and 8. I think even one I saw went to 9. And that was been kind of rare. Most of the time it's been 5 days on plans. And then 7 was some of the other ones they would. So you would have a copay for those days, but if you're in the hospital for 2 weeks, you're still only going to pay a copay for 7 days. And so the insurance company is paying the rest of the cost for that second week. And that's what I'm saying. You're not going towards your maximum out of pocket because you only had to pay for, and I say only, but you only had to pay for 7 days. You didn't have to pay for 14. So it's other procedures, repeat procedures that will cause you to approach that maximum out of pocket. Of course, anybody who's on dialysis, they're going to hit their max out of pocket every year because they have that. They're going to treatment 3 times a week, and those aren't cheap. And the insurance company is charging them a copay each time they go until they hit that max out of pocket, and then it's done. Now, a lot of times the American Kidney Foundation helps some of the people with some of those costs too. So it's not so much, it doesn't hit that member that much, but the insurance company is still having to pay that cost. So, and that's what I say, they balance it out from that person who goes to the doctor, once or twice a year for a checkup, has a couple of generic prescriptions or no prescriptions. It averages out. And that's why and I've explained this before, and if I haven't talked about this, is Medicare did a study with Harvard back in the late 90s, or actually, no, it was before the late 90s, because before they put in the Medicare, it was early 90s, that at that time, Medicare's average, they said Medicare was paying $7,000 per, as CMS calls a Medicare beneficiary. If you have Medicare calls you a beneficiary of that benefit, and they were paying $7,000 per person is what they averaged out. So that's when they came up with the idea of the Medicare Advantage plans, let the insurance companies balance those costs, and they would subsidize them. And like I said, they were subsidizing at about $7,000-8,000. Now it's $10,000 to $12,000 a year, or not a year. $1,000 to $1,200 a month that they're subsidizing that health plan. So anyway, back to what I started on is, so this year a lot of the plans, the PPOs are the ones that usually end up being more expensive for the insurance companies because people are going to doctors and hospitals that they don't have as good a reimbursement rate negotiated. So that's why one of the things that will happen is it will end up costing the insurance company more, and it'll cost the individual more too, because PPOs, you're going to have a higher maximum out of pocket and usually higher co-pays. If you're seeing an out-of-network provider, you could have some deductibles come into play there, or just a higher co-pay. So a lot of the plans is that we just can't balance the costs on these PPOs. We don't, we're losing money on them. We don't want any more people to sign up on a PPO. So they send out a notice all us agents and say, this plan here, even though it's still available, we're no longer going to pay you commission on it. Or a couple other things they did is like, we'll pay you commission on this plan if you fill out a paper app. And I did a lot of paper apps when I started at this back in 2014, but I haven't done a paper app for Medicare in I don't know how many years. Everything's online. It's all electronic. We don't want to do a paper app. So we would avoid those plans, or we're going to offer a plan that is hopefully we're still going to offer a plan that's going to be in your best interest, but we may have to hold our nose, as we say, so to speak, and put you on a plan that doesn't pay us commission. I've had to do that lately with some of the drug plans, and a lot of the drug plans are not going to be commissional. The plans that are going to be the right plan for you, if you have a Medicare supplement and a separate Part D, are going to be those non-commissional plans, especially if you're again, that example, you have a couple of little cheap generics, or you take nothing at all. You do still probably need to get a low-cost drug plan so you don't have the late enrollment penalty when you need a drug plan later. And there is, believe there's going to be 2 zero-premium plans available this coming year. Don't know for sure yet. Some of those costs are still up for negotiation. But, I'll recommend those to people if that's the right plan for you. And as I've mentioned before, we have the Canadian Med Store, because a lot of those plans, they may be covered under your health plan, but they're still going to be more expensive than if you order them through that Canadian Med Store. It doesn't seem like it should make sense, but it does. We can save you a lot of money on that. So, and in some of the plans that are still available for next year, they put their bids in, and now they've kind of reevaluated and gone, no, we really don't want to get any more people than we have to on that plan, so we're going to make that plan non-commissionable. So a lot of changes there. Got a carrier from, I'm also licensed in Texas. I got an email yesterday, and basically this carrier is saying that all of their Medicare Advantage plans are not going to be commissionable except for what we call the DSNP, the Dual Special Needs Plans, and that's for those individuals who are on Medicare and Medicaid. Now, when I'm talking to people in another state, those aren't necessarily the people that I'm talking to. I'm talking to the people who are just shopping their plans. So I want to try to find a plan that's going to pay me. So that's kind of what's going on in the Medicare side of things. So they're making a lot of their PPOs non-commissionable. They're discontinuing a lot of plans. And that's one of the things that's going to affect a lot of people, and that's why I've been harping on the get with us, go to my website, and you don't have to schedule an appointment at that time, but if you go to my website, go to my calendar where you can schedule an appointment, there's some instructions on the, if you want to do a Medicare enrollment. I call it a Medicare enrollment. You may already be enrolled in Medicare, but if I'm going to enroll you in a Medicare plan, such as changing your Medicare Advantage plan or looking at maybe changing your Medicare supplemental plan, on my status, I call that a Medicare enrollment because it's not a under 65 ACA healthcare enrollment. And after the break, I'm going to talk a little bit more about ACA happenings. But there's a link. Currently I'm using an app called Retire Flow. And so there's a link in there to go and fill out that form. And I read an email this morning. They've done some updates to that form that's going to ask a couple other questions, kind of help figure out what's going to be the best plan for you. I think they're adding a section to other things you'd like us to know. So in that box will be a great spot to put, this is I have a Humana Gold plan, or I have a Blue Advantage, or just whatever plan you have. If you can give us the plan number, that would be great. And so I can compare and know, because what's happening, a lot of those plans are going away. As I mentioned, they don't want people on these PPOs. So a lot of the plans they made non-commissionable for this year, if we were signing somebody up new because they moved or something, a lot of those plans aren't going to be available in 26. And the other issue there is, sometimes they'll do what's called crosswalk, whereas, this plan's no longer available, we're going to move you to this plan. A lot of that's not happening. So it really makes sense, even if you think, hey, I love my plan, it's great, you should be getting that letter, that annual notice of changes, and double check that letter. Again, it's going to come from the insurance company. It's not going to look like your typical spammy emails that are, glossy postcards. It's going to be in an envelope, but it will be from your insurance company, and you really do need to read that. But fill out that Retire Flow form. We can kind of start shopping your plans that first week of October. And we can say, okay, yes, I think there's a couple plans that make sense for you to change. Let's schedule an appointment and come in. Or if you don't want to come in, I use a program called Sunfire that I can send you the quotes. And then there's a little green button in the quotes, and you can click enroll in that, and you can sign up for the plan that one of the plans that I'm recommending, and you won't have to come to the office. But either way, we want to get that going. So we're up on the break here, and like I said, after the break, I'm going to talk about some stuff about the under 65 ACA plans.
Twin Lakes, the people who bring you better internet are now bringing you better wireless. Introducing Tri-Lite Mobile, a new wireless service for the Upper Cumberland. Enjoy nationwide coverage, the freedom to bring your own device, and budget-friendly plans, all backed by the local team you know and trust. Right now, when you sign up or upgrade your internet service, you'll get your first line free. Ask about Tri-Lite Mobile from Twin Lakes today. Call 931-476-2355 or visit twinlakes.net. Some restrictions may apply.
Join Habitat Restore at their pop-up donation event every second Saturday of each month at First National Bank in Sparta. The Habitat team will be there ready to go to receive your donations. So don't miss an opportunity to declutter and make a difference at First National Bank in Sparta with the Habitat Restore pop-up donation event every second Saturday of the month.
And now, back to Insurance Matchmaking with Matt Libby Insurance.
All right, welcome back to Insurance Matchmaking. And as I was talking before the break, I was talking about some of the changes that are affecting what's going on with the Medicare enrollments this year. And, like I said, encouraging everybody, reach out to us. If you have a local agent, reach out to that agent. Don't call the 800 numbers. Don't call the insurance. Let us help you there, because we'll give you the advice. And we know the plans around here. Elijah is in the process of getting his different certifications. He has passed the infamous AHIP. That's the first stage we have to go to be able to enroll people in Medicare Advantage plans or Part D drug plans. And so he's got that net. Now he just needs to get going with the carrier certifications, and hopefully we'll have some of that done at the time you're listening to this program. But just kind of wanted to reiterate on the ACA. There's a bunch of big changes there. A lot of stuff people think it's because of the one big beautiful bill, and again, that did not what that bill didn't affect the ACA, the under 65, also known as Obamacare plans. It didn't affect those things much directly. It was more indirectly, and that was because some of what we had was called the enhanced subsidies that came out of the American Rescue Plan during the Biden administration, but those were all set to sunset, as they say, on December 31st, unless they were extended. A kind of example on that in the One Big Beautiful Bill Act was the Trump tax cuts from his first administration. They were set to expire. They put those tax cuts in, and some of the others, they made them permanent. And when we say permanent, it doesn't mean they can't change, but they don't have an expiration date. It does take another piece of legislation to remove or change those tax rules. The enhanced tax credits on the marketplace were set to expire on December 31st. So because they had an expiration, for them to continue, then it would have required legislation to extend them. And that is what didn't happen in the One Big Beautiful Bill. None of those things were extended. There's been some rule changes coming out of CMS for the under 65 health, and one change that's come about recently is a good change. I'll expand on that here in a bit. But it's going to affect some in the lower income, because some of those, like we said, there was enhanced subsidies. So somebody that maybe was making $30,000 and was paying $20 for a silver plan, this next year they maybe have to pay $100 for that plan. Or maybe, a family that was paying $150 for their family plan, maybe looking at $320. And I'm just spitballing some numbers. I haven't gotten around to looking at the Kaiser Family Foundation, and I think you can go to kff.org. You can search there. They do have what am I trying to say? Not a table, but they have an app on their website that you can put in your family information of, okay, we have this many family members. This is what we anticipate our income to be. And I think you could even put in what current plan you have or what you're currently paying for your plan, and it will calculate, okay, yes, if you keep that same plan, your premium's probably going to be this in 2026. Like I said, that's one of the things. The time you listen to this, I probably will have checked that out, but I haven't gone and checked that out personally yet. But that can kind of give you an idea of what your health plan is going to cost you next year. The biggie, and again, I know I've talked about this a lot, is what I call the tax credit cliff. There's another person I follow on Facebook, or not on Facebook, but on YouTube, and some of his videos he's been referring to the cliff too. It's the first time I've heard somebody else talk about it being a cliff. But what happens is, if your income is over 400% of the poverty line, you're not eligible for a tax credit. And then what gets people in trouble is they underestimate their income, and they're at 390% of the poverty line, so they qualify for the tax credit, and it's still a pretty substantial tax credit. A family, a couple maybe getting $800 a month tax credit, and so they're paying $1,200 a month or $800 a month for their health insurance. And then the next year when they go to file their income tax, and their income put them at 405% of the poverty line, they're not eligible for the tax credit that they received. So that $800 a month that they were getting that was going towards their already high health plan, they owe all that back. 800 times 12, that's almost $10,000. So, or close to $10,000. So that's not going to be a nice situation when it comes to tax time. Now, unfortunately, sometimes because of pre-existing conditions, the marketplace plans are the only solution for a lot of people. But if you're relatively healthy, sometimes it makes sense to go a different route. And especially if you're going to pay full price for the marketplace plan because you're not eligible for any subsidies, it still may make sense because that's going to be the best coverage for one family member due to because of the income, but because of their health, that's the only plan that's going to cover them. The other spouse that's relatively healthy, there are alternatives for those high costs. One of the ones I've talked about, I have gotten contracted with Medicare. I had that several years ago, went back in my early days with health markets. Health markets decided a year, 1 or 2 years, that wasn't more than that we did the health sharing plans, and then they determined that just wasn't working real well for us, and the tax penalty went away for not enrolling in a marketplace plan. So that was one of the big incentives there too, was people were like, I don't want a marketplace plan. I don't want to pay the cost for it. I'm not eligible for a subsidy. So I'm not going to take that plan, but they were facing a tax penalty. So they would do you could do a plan like Medishare and other health sharing ministry plans were exempt from that tax penalty. Well, the tax penalty doesn't exist now, so that's not one of the reasons. But if you're not going to be eligible for the subsidy, is a big reason. Now, the beauty of the Medishare plans is they're not going to turn you down for a pre-existing condition, but if you have a pre-existing condition, then that's not going to be shareable, as they call it. So you're not going to be able to share the cost. For example, if you are doing kidney dialysis, I just used that as an example, you won't be able to share the costs of that with the other members until you've been on the plan for 3 years, and then it'll be shareable. So that's not going to be probably a good option for most people. A marketplace plan is still probably going to be a better option, even if it's a very high premium, because you will hit a maximum out of pocket, and then it'll cover it. And as again, I've mentioned the Kidney Foundation before about dialysis with Medicare plans. Some of the plans that do assistance will pay for the deductible. And then when they pay the deductible, and then the health plan pays the rest after that. So there are some ways there. But if you're relatively healthy, you want to have your family all on the same plan. Your kids aren't going to qualify. If you have kids and they're not going to qualify for the children's health assistance program through the state because of your income, a family plan with Medishare can be very useful. And a neat thing with the Medishare plans, the family plan is one rate. It doesn't matter if you have one child or you have 5 children. You're going to pay the same amount each month. So that can be a very viable alternative. And we do have a companion plan that goes with that. It's called Wellness Share. That will cover, you pay a little bit extra, but it covers your preventive, and there's some options in there also where there's 3 options. And the 2 higher options also will include some reimbursement for like a hospitalization, things like that. So a lot of times it makes sense to get a plan with a higher annual household share, annual household portion as they call it, and take that and add that partner plan, because it will because you're not going to hit that annual household share generally unless if you have like $6,000 or $9,000. You're not going to hit that unless you're not going to hit that annual household portion unless something catastrophic happens. Somebody got hurt, emergency room, somebody got admitted in the hospital, a surgery, things like that. They're going to raise that cost because they do go down to like a $3,000 annual household portion. But that $3,000 plan is going to be a lot higher than the one that has a $12,000 annual household portion. That's where that, like I said, that companion plan that will cover the preventive stuff that's not covered, that you have to pay out of pocket with the regular coverage, and then have that balance in there for hospitalization or something. You still have to pay, you're still going to pay that. You're going to get the bill even if you're getting reimbursed, but it still goes towards your annual household portion, and then your medical costs start sharing, but you got help with that deductible along the way. We also have other supplemental plans, cancer plans, accident plans, critical illness plans that will again reimburse for those big ticket costs And so that way you don't worry about that annual household portion. Another alternative is the short-term plans. We do have the back now where we can sell you three 364-day plans. You're not paying for 3 years, but you can have that plan for 3 years. When I'm saying you're not paying for, you're not locked in that, oh, I signed up for this, I have to pay for it for 3 years. You can still cancel it at any time, but what you go through the health underwriting the first year, and in years 2 and 3, you're gonna have you'll have a rate increase because you're a year older. Rates will go up some. There is one plan that does offer you can set your rate for the 3 years. I generally don't recommend it because most of the clients I've had haven't done the whole 3 years. I've had a few that have, but a lot they take the plan because it's a great alternative, and then they change jobs and they're offered, and so they cancel the plan, or their income changed and it made more sense to go with the marketplace. So there's reasons you might change the plan. So I usually say don't do the 3-year lock-in because it's going to be higher when you start. Just go ahead and take the increases as they come in year and 3. After that 3rd year, you're going to have to apply again. Now, again, most of my clients that go for these are usually my older clients that are just wanting that bridge from they retired early at 62 or 63, started drawing their Social Security, but they're not eligible yet for Medicare for a couple more years. And so they may do that one of those plans and then go on Medicare when they turn 65. The third alternative is another plan that I have from Manhattan Life that's called the Affordable Choice, and it is a fixed benefit plan. And it's not the only fixed benefit plan that I have available, but it'll pay so much for a doctor visit. It'll pay so much for a day in the hospital. It's so much for a surgery. It'll reimburse some for prescriptions. And I don't want to get too much in details, but there's 4 levels to it. And one of the things I really like about this plan is we can look at the brochure and it shows you exactly what it will pay for such and such a procedure or a hospitalization. And then on the next page, it breaks down the rates in their age banded, like from 29 to 40 or something like that. I can't remember where the age breaks are right now. But if you're in that age range, that's what it is. And it breaks it down for an individual, a couple, single parent, and for a family. And those rates are right there. And they're, when you're looking at it, oh, I like the Elite Plus, and I need to get that for my family. And it'll be based on the oldest spouse, which age band you're in, and you look at that and go, okay, this is what it'll cost me for my family. And that's what the cost is going to be. Now, I do believe they will, I don't know that they lock your rate in on those. I think when you hit that next age band that you do have a price increase, and I'll have to check on that. I just realized I can't remember which way that one goes. So that's one of the things you can do. And I didn't touch on the Medicare. I have something here. I was looking at my notes, and it's like, I'll talk about that on another show. But the biggest things are that we need to really look at your Medicare plans and your under 65 health insurance plans. We got till November to do that. There are permission forms. There's information forms that you can submit to us, so we kind of have that information when it comes time. But I'm not going to be able to really give you rates on your health insurance until